Hi, my name is Dr. Diane Spatz. I am a nurse researcher and director of the lactation program at the Children's Hospital of Philadelphia, sharing a joint appointment with the University of Pennsylvania School of Nursing, where I am a full professor. Today I'm going to be sharing with you evidence-based strategies for human milk. Many hospitals have relied solely on international board-certified lactation consultants to provide lactation support. Unfortunately, in the United States, there are only about 3 IBCLCs for every 1,000 births. Many women do not have access to lactation consultants. We need to develop models so that nurses can provide evidence-based lactation support. We have developed one such at CHOP called the Breastfeeding Resource Model that has over 14 years of published data on our positive outcomes of nurses providing lactation support. My 10-step model for human milk and breastfeeding in vulnerable populations has 14 years of research outcomes and clinical practice outcomes. When you focus your attention on this 10-step model, you must focus directly on the first 5 steps to ensure outcomes of human milk and breastfeeding at discharge. Tampa General Hospital recently published about implementation of my model, and they were able to have increased human milk rates 3-fold at discharge. Many women, at least in the United States, do not initiate pumping or breastfeeding for their infants because of cultural barriers, lack of family support, lack of education and exposure to breastfeeding. So human milk in the NICU must be treated like a medical intervention. And we have developed a powerful motivational video called The Power of Pumping, which can be viewed at the web link below. In order for a mother to be able to sustain milk production long term, she must pump early and often. Mothers really must pump within 1 hour of giving birth to their NICU baby. The earlier they pump, the more milk that they will make. We need to pay attention to the first 2 weeks of pumping, where mom's only job should be to eat, sleep, pump, and visit her baby. If we focus on the first 2 weeks of pumping, we are going to have mothers who are able to sustain milk production long term, as we do at CHOP, where the majority of mothers who deliver with us make over 1 liter of milk per day. We also want to ensure that we are using human milk for oral care. Human milk oral care has benefits for the infant, but it also has many benefits for the families. It empowers them, it makes them feel included in their child's care and have positive progress feelings. And for the mother, it is a strong motivator for her to keep pumping and build her milk supply. Pumping is hard work. Anything we can do to motivate the moms to pump is essential. We also need to be able to appropriately optimize milk. That means we need to make appropriate decisions regarding analysis, fortification, the ability to make skim milk for babies with chylothorax, and we also must have donor milk available in the absence of mom's own milk. One strong message I want to be very clear on is that donor milk is never a replacement to mom's own milk. It is a bridge. So we always want to focus on the provision of 100% mom's own milk diet, but have donor milk available as a low-cost intervention if mom's own milk is not available. If the mother's goal is to directly breastfeed, we have to support her in that transition to direct breastfeeding. For that transition, mom is going to need access to technology. A breast pump, pre- and post-weights are essential to determine milk transfer, and the mother may need other technology such as the nipple shield. So, in summary, the top 10 findings are noted below, and I thank you for your time and attention.